All right, I'm going to kick this thing off. Thank you, everyone, for your patience. I appreciate it. I want to welcome you to today's Payer Forum presentation. First, let me welcome you to the Spring Georgia HFMA 2022 Virtual Spring Payer Forum. My name is Bill Ikest. I'm a past president of the Georgia chapter of HFMA. We appreciate you joining us. We've had these meetings in person, as you know, in the past, and the last couple of years have moved them to virtual because we still believe they are very, very valuable. So we appreciate your participation, and these sessions are being recorded, so they'll be out on the chapter website at some point. I'm thinking probably at the end of this week or early next week, and I'll show you at the end of this presentation how to access those. I just want to remind you, if you have questions for the panelists today, if you would please drop those into the question and answer section found on your screen. No specific PHI questions, of course, but if you'll just list any other questions, issues that you have that the folks on the call can address, we'll be sure that they get those answered, or we'll get back to you with the information that you need. So thank you very much. This session is scheduled to run just about an hour. We may not need all that time, but I've asked the presenters to run through their updates and leave plenty of time for questions as well from all of you. So thank you for your support, and I will turn it over to Palmetto Gba. Thank you.
Thank you so much, Bill, and welcome everyone. I do want to apologize. We were having some technical difficulties connecting to the webinar, so we got on here a little bit late. I'm not able to see the slides, but Bill's going to drive for us this morning. But let me introduce myself. My name is Ulrika Freeman, and I'm with Palmetto Gba. I'm a Senior Provider Relations Representative, and I want to welcome you here. Thank you for joining us for the Palmetto Gba session of the Georgia Health Finance Management Association Spring 2022 event. Coming up after me is my coworker, Sandra Booker. She's one of our nurse panelists, and she'll go over some other clinical information with you all. Next slide, please, number 2.
Okay.
Okay, thank you so much. As a disclaimer, the information that we're sharing today was current as of April 15, 2022. Any information superseding this information will be provided on our website at www.palmettogba.com, or it will be on the CMS website. As a note, CPT codes and descriptions and other coding data is copyrighted by the American Medical Association. So today's agenda. What we're hoping to do is provide pertinent updates, changes, and reminders. I'm sorry, I didn't tell you to switch the slide.
I got
slide 3, please.
I'm with you.
Provide pertinent changes and reminders to assist the provider community in staying informed about changes and updates to Medicare. My screen keeps going out. Okay. So today's agenda, we will talk about CMS 1750, the final rule, which is the CMS publication 1752F overview. We're going to give a background on IPPS and LTCH PPS, changes to payment rates under IPPS and LTCH PPS, and the use of the fiscal year 2019 inpatient hospital utilization data, implications of using FY 2019 data, and the changes to the new COVID-19 treatment. We'll also discuss closing the health equity gap. We'll discuss some dual eligible individuals and the disproportionate share hospital payments. And we'll talk about a few uncompensated care payments. And after we go through those things with the final rule, I'll give some key takeaways and point you to a few resources. We do not have a survey for you to complete for this particular session. However, Bill may have a survey for the whole webinar. I'm not sure.
Yeah, that's what we're hoping to do. Thank you, Rika.
Okay, so we'll go to slide 4, Bill, if you don't mind. And so fiscal year overview, we're going to talk about the final rule briefly. So on August the 2nd, 2021, CMS posted the final rule, fiscal year 2022 inpatient prospective payment system final rule, which is the IPPS. The date of the publication was August the 13th, 2021. Slide 5.
Okay.
CMS issued the final fiscal year 2022 IPPS and the LTCH PPS final rule subsequent parts. CMS received more than 6,500 public comments on the fiscal year 2022 IPPS and the LTCH PPS proposed rule related to disproportionate share hospital payments, organ acquisition costs, and provision of the Consolidated Appropriations Act, CAA 2021, related to payments to hospitals for direct graduate medical education and indirect medical education, IME costs. We were hoping that these changes will promote interoperability program requirements for eligible hospitals and critical access hospitals, and it addresses the challenges related to the COVID-19 pandemic and changes to Medicaid provider enrollment, also changes to Medicare Shared Savings Program. Slide 6. CMS pays acute care hospitals for inpatient stays under the IPPS. Long-term care hospitals are paid under the LTCH PPS. Under these two payment systems, CMS sets base payment rates prospectively for inpatient stays based on the patient's diagnosis and the severity of the illness. Subject to certain adjustments, a hospital receives a single payment for the case based on the payment classification assigned at discharge. The law requires CMS to update payment rates for IPPS hospitals annually and to account for changes in the prices of goods and services used by the hospitals in treating Medicare patients, as well as other factors. This is known as the hospital market basket. The hospital market basket. The IPPS pays hospitals for services provided to Medicare beneficiaries using a national-based payment rate adjusted for a number of factors that affect hospital costs, including the patient's condition, the cost of hospital labor in hospitals, in the hospital geographic area. CMS updates LTC payment rates annually using a separate market base on LTCH specific goods and services. Slide 7, please. Hospitals may be subject to adjustments under IPPS. And this is because payment reductions for excess readmissions under hospital readmissions reductions program, payment reductions 1% for the worst performing quartile under the hospital acquired condition reduction program, and upward and downward adjustments under the hospital value-based purchasing program. So slide 8, the fiscal year 2022 LTCH PPS payments to increase. For 2022, CMS expects LTCH payments to increase approximately 1.1% or $42 million. LTC PPS payments for fiscal year discharges paid standard LTCH payment rates are expected to increase by 0.9%. Yeah, that's 0.9. LTCH payments for fiscal year 2022 for discharges paid, the site neutral payment rate is expected to increase by 3%. This is due primarily to the annual standard federal rate under fiscal year 2022 of 1.9% and the projected 0.8% decrease in the high cost outlier payments as a percentage of total LTCH PPS standard federal payment rate. CMS estimates that discharges paid, the site neutral payment rate will represent approximately 25% of all long-term care hospital cases and 10% of all LTCH PPS payments for fiscal year 2022. Slide 9. To use the best available data. The goal of CMS is to use the best available data overall when setting inpatient hospital payment rates for the upcoming fiscal year. Ordinarily, the best available full-year data to approximate the fiscal year's expected fiscal year 22 inpatient hospital would be data from 2020. But however, due to the public health emergency, they did not do that. The fiscal year 2020 data reflects changes in inpatient hospital utilization driven by the COVID-19 PHE. The vaccinations in the Medicare population, coupled with the effectiveness of the vaccines, leads us to believe that there will be significantly lower risk of COVID-19 infection and fewer hospitalizations for COVID-19 in fiscal year 2022 than occurred in 2020. We are using the fiscal year 2019 data from the prior to the COVID-19 public health emergency to approximate the expected fiscal year 2022 inpatient hospital utilization. And that is due to the access of vaccines and hoping that we'll get the COVID public health emergency under control. Slide 10, new technology and add-on payments. Since IPPS payments are generally based on the most recently available Medicare claims and the cost report data, which tends to have a lag of 2 to 3 years, the statute provides temporary additional payments for cases with high costs under the new technology add-on payment, or the NTAP policy. Under this policy, Medicare pays the applicable MSDRG payment rate and up to an additional 65%. The new technology add-on payment is not budget neutral and is generally limited to a 2 to 3 year period following the date the product begins to become available. So for fiscal year 2022, in connection with CMS's decision to use fiscal year 2019 instead of 2020 data for fiscal year 2022, IPPS rate setting, CMS is finalizing a 1-year extension of the new technology add-on payment for 13 technologies for which the new technology add-on payment would otherwise be discontinued beginning fiscal year 2022. Slide 11, add-on payment with NCTAP. CMS is not finalizing the proposal to discontinue the NCTAP for discharges on or after October 1st, 2021 for product that is approved for new technology add-on payments beginning fiscal year 2022. Instead, hospitals will be eligible to receive both the NCTAP and the traditional new technology add-on payments for qualifying patient stays through the end of the fiscal year in which the PHE ends, with the new technology and add-on payments reducing the amount of the NCTAP. In response to the COVID-19 public health emergency, CMS established the new COVID-19 treatment add-on payments for eligible discharges during the PHE. CMS anticipates inpatient cases of COVID-19 to the end of the public health emergency. Therefore, to continue to mitigate potential financial disincentives for hospitals to provide new COVID-19 treatments and to minimize any potential payment disruption immediately following the end of the public health emergency, CMS is extending the NCTAP for eligible COVID-19 products through the end of the fiscal year in which the PHE ends. And hopefully that will be really soon. Slide 12. Some of this, of course, I'm reading because it's just cut and dry, and there are really no changes that I can make it better for the final rule. It's just what it is. It's the final rule. So just bear with me so that we'll understand it. But CMS established the NCTAP for eligible discharges during the PHE. CMS anticipates inpatient cases of COVID-19 beyond the end of the public health emergency. CMS is extending the NCTAP for eligible COVID-19 products through the end of the fiscal year in which the PHE ends. to continue, and I just said that, to continue to mitigate the potential financial disincentives for hospitals and to provide new COVID-19 treatments and minimize any potential payment disruption immediately following the PHE. Slide 13. CMS also sought comment on the potential development of the health equity score measure model of the health equity summary score applied to Medicare Advantage plans data, but adapted to the context of risk-adjusted hospital outcome measures and potentially other hospital quality measures used in the CMS program. CMS received many comments in response to the RFI, reflecting the importance of these policies. CMS will consider this input carefully in developing all future policies. That's slide. So slide 14, please. The final rule as it relates to the dual eligible individuals. Medicaid enrollment of Medicare providers for purposes of determining Medicare cost sharing payments for dually eligible individuals. Through the Medicare Savings Program and Medicaid statutes, states cover the Medicare cost sharing for over 8 million dually eligible individuals. However, through what is commonly referred to as the lesser of policies, states are allowed to pay less than the full Medicare cost sharing or in certain circumstances, make no payments at all. 43 states currently have a lesser of policies for inpatient hospital cost sharing, and that's just unfortunate, but they can pay a little less. Slide 15. If states pay less than the Medicare cost sharing amount, certain Medicare providers may submit these unpaid cost sharing amounts to Medicare for reimbursement or for bad debt. For a service provided to dually eligible individuals, this typically means furnishing a Medicare remittance advice showing what the state paid or what the state did not pay. However, some states in the past have hindered some Medicare providers from enrolling in Medicaid. As a result, these non-Medicaid enrolled providers may not be able to submit a claim for payment of Medicare cost sharing and receive the remittance advice to submit for claiming of the bad debt. Slide 16. Under the CMS final rule, CMS will require state Medicaid provider enrollment systems to allow valid enrollments from all Medicare providers serving certain Medicare, Medicaid dual eligible individuals, even if the provider or supplier is out of state for purposes of processing cost sharing claims for services furnished to these dual eligible individuals. Slide 17. In Section 1886 of the Act, as added by Section 3133 of the Affordable Care Act, which provides for a reduction to disproportionate share hospital payments under Sections 1886 D5F of the Act for the new uncompensated care payments to eligible hospitals. If the hospital treats a high percentage of certain low-income patients, it receives a percentage of add-on payments applied to the DRG adjusted base payment rate. This add-on payment is known as the disproportionate share hospital adjustment, provides for a percentage of increased Medicare payments to hospitals that qualify either under two statutory formulas designed to identify hospitals that serve disproportionate share of low-income patients. Slide 18. Like I said, the Act is the Section 1886R of the Act that requires this, and the 25% of the amount they previously would have received under the section of the Act is the DSH is the empirically justified amount. An additional payment for the DSH hospital's proportion for uncompensated care determined as the product of three factors. Slide 19. The three factors are 75% of the payments that would otherwise be made under the section of the Act, 1 minus the percent of the individuals who are uninsured and a hospital's uncompensated care amount relative to the uncompensated care amount of all DSH expressed percentages. The Act specifies 2 methods by which hospitals may qualify for the DSH adjustment. The first method, hospitals are located in an urban area and have 100 or more beds may receive a Medicare DSH payment adjustment if the hospital can demonstrate that during the cost reporting period that more than 30% of its net inpatient care revenues are derived from state and local government payments for care furnished to patients with low income. This method is commonly referred to as the Pickle Method. The second method for qualifying for DSH payments adjustments is based on a complex statutory formula under which DSH payments adjustment is based on the hospital's geographic designation, the number of beds in the hospital, and the level of hospital disproportionate patient percentages. Slide 20. The Medicare fraction, also known as the Ssi fraction or the Ssi ratio, is computed by dividing the number of the hospital's inpatient days that are furnished to patients who are entitled to both Medicare Part A and supplemental security income benefits by the hospital's total number of patient days furnished to the patients entitled to benefits under Medicare Part A. The Medicaid fraction is computed by dividing the hospital's number of inpatient days furnished to patients for such days were eligible for Medicaid, but were not entitled to the benefits under Medicare Part A by the hospital's total number of inpatient days in the same period. Slide 21. Consistent with the policy adopted in the fiscal year 2021, IPPS, LTCH, PPS final rule for fiscal year 2022 and subsequent fiscal years, CMS will use a single year of data on uncompensated care costs from worksheet S10 of the hospital's fiscal year 2018 cost reports to distribute these funds. CMS will continue to use data regarding low-income insured days to determine the amount of uncompensated care payments for Puerto Rico hospitals, Indian Health Services, and tribal hospitals for fiscal year 2022, similar to the fiscal year 2021 methodology. Now we gotta have a few takeaways from the final rule, some key takeaways. That would be slide 23, slide 23, please. The first key takeaway is CMS estimates that the payment update and other rule changes will increase payments to hospitals in fiscal year 2022 by $2.3 billion. This estimate does not factor in the changes in hospital admissions, real case mix intensity, or the mandatory sequestration adjustment. Key takeaway number 2, slide 24. The fiscal year 2022 standardized amount for hospitals that successfully participate in the hospital inpatient quality reporting program and that are meaningful electronic health record users will be $6,121.71, an increase of about 2.7% compared to fiscal year 2021 standardized amount. Slide 25. Sorry about that. So CMS, key takeaway number 3, CMS will use fiscal year 2019 Medicare provider analysis and review the MedCard data for fiscal year 2022 rate setting process, given the impact of the public health emergency of the COVID-19 public health emergency on inpatient utilization and case mix for fiscal year 2020. Key takeaway number 4 here, slide 26. As a one-time exception and because of the pandemic impact, CMS will provide a 1-year extension for 13 technologies whose new technology add-on payment period was scheduled to expire. Hospitals will receive neutral payment adjustments under the Hospital Value-Based Purchasing Program for fiscal year 2022. Slide 27, key takeaway number 5. As CMS finalized a payment increase of 2.7% for hospitals that successfully participate in the reporting program, fiscal year 2022 standardized amounts are the sum of the labor-related and non-labor-related shares without adjustments for geographic factors. The labor-related share reflects the proportion of the federal-based payment that is adjusted by a hospital's wage index. For fiscal year 2022, CMS has finalized as proposed the downward revision of labor-related share from 68.3% to 67.6%. This change is the result of the statutory requirement and should have limited impact on fiscal year 2022 and future IPPS payments for most hospitals. Slide number 28. So these are some of the numbers that I just discussed, and you'll see the hospital submitted quality data is meaningful EHR user is 6,121.71, which is for 2022, which is up from the 5,961.19 from 2021. The hospital submitted quality data is not a meaningful EHR user. It's up to $6,000.17, and that's up 2.5% from the 5,856.40. The hospitals that did not submit quality data and is a meaningful EHR user, that is up 2.6%. It's now $6,081.19, and that's up from the 5,926.26 from 2021. Hospitals did not submit quality data under the meaningful EHR user. That was a 2.4% change, and that went from 5,821.47 to 5,959.67. Slide 28, please. I'm sorry, 29. Key takeaway number 6. As market-based MSDRG relative weight methodology and data collection change in methodology for calculating MSDRG relative weights, CMS repealed the policy that would use market-based data for calculating Medicare severity diagnosis-related group relative weights, including its requirement to report Medicare Advantage data. MSDRG changes. CMS finalized its proposal to use fiscal year 2019 MedPAR data and the fiscal year 2018 healthcare cost report information system file for analyzing MSDRG changes and determining MSDRG relative weights for fiscal year 2022. Slide 30. Here. New technology, key takeaway number 7, new technology add-on payments. CMS finalized its proposal to use fiscal year 2019 MedPAR data for establishing proposed fiscal year 2023 threshold values. Because of the pandemic's impact on utilization, CMS finalized its policies as proposed to use fiscal year 2019 MedPAR data instead of 2020 data. CMS made no changes to the other criteria it considers when evaluating new technologies of eligibility for add-on payments. Slide 31. Key takeaway number 8, extension for technologies with expiring NTAP period. CMS finalized a 1-year extension for technologies whose NTAP period was scheduled to expire. CMS also implemented a one-time NTAP extension for new technologies expiring NTAP periods. This policy applies to 13 technologies and services. The one-time extension of the NTAP period is also consistent with the proposed extension of the transitional pass-through period in the hospital outpatient setting. Slide 32. NTAP applications for fiscal year 2022. In the proposed proposed rule, CMS discussed 37 NTAP applications. Following the withdrawal of some applications, CMS rendered decisions on 31 NTAP applications. Of these, 18 devices and drugs applied through the traditional pathway, and 13 went through alternative pathways. Of the 31 applications discussed in the final rule, CMS approved 17 new services and technologies for the add-on payment. Slide 33. Key takeaway number 10. There will be 40 technologies and services eligible for NTAP in fiscal year 2022. Taking into consideration the 13 new technologies that received a one-time extension of their NTAP period, 10 new technologies that were approved for fiscal year 2021 and will still be in their NTAP period in fiscal year 2022, and the 17 newly approved technologies. And the last one about the final rule. Key takeaway number 11. In response to the public health emergency and considering the development of new drugs and biologics for COVID-19 treatment, CMS established a new COVID-19 treatment and add-on payment for the NCTAP, starting with discharges on or after November 2nd of 2022 that met a certain criteria. Acknowledging the pandemic's continued financial impact on hospitals, CMS finalized this policy to continue the NCTAP for qualified technologies that do not qualify for the NTAP or for the NTAP. The NCTAP remains in effect until the end of the fiscal year following the end of the public health emergency. I know it's some dry information, but the final rule doesn't change, so there's really no hoopla to it. At this time, though, I'm going to turn this over to our nurse, Sandra Booker. Sandra?
Thank you,
Erica, thanks for your participation, Erica. I appreciate it. I know it's a lot of information. There's really no fancy way of presenting it, but we appreciate it.
Thank you.
Okay, again, thanks, Erica. And I'll be going over some clinical education, targeted probe and educate, or TPE, medical review, hot topics for TPE, and the new hospital outpatient department OPD prior authorization CPT codes.
Hey, Sandra, I had a question come in. Can I throw this out so that either of you can maybe think about it, or maybe if you're going to get to it?
Yeah.
Yeah, so someone said they've been having an influx of outpatient claims being denied for not being billed within 4 days of an inpatient stay. Has the rule changed that outpatient services now must be billed on an inpatient claim if that fell within 4 days prior to the inpatient stay? She asked a customer service rep, and she said not really, yet the claims are being rejected if services are 4 days prior to the inpatient visit. Does that make sense?
It makes sense. Charles, go ahead. I'm sorry.
Normally, claims like that, services are bundled in. Now, they may need to put a note on the claim if it's not related to the inpatient stay. So probably need to be more specific when they talk to the contact center. If it's not related to the inpatient stay, then they could give them direction on what to do to get that claim through. But if it's related to the hospital stay, those are generally just bundled into that service. So those normally do reject.
Okay, let me see if there's a follow-up on that. And for the person that asked the question, I can certainly put you in touch with them as well if you need to discuss that in more detail. The follow-up question from them is, but what about the time period? Is it 3 or 4 days?
It historically has been 3. You might need to just put them in contact with us. We might have to look and see what exactly is going on.
Okay.
Because if it's truly the 4th day, normally those would go through. So it might be something else happening. That's a glitch in the system.
Okay. Okay, go ahead, Sandra. I'm sorry.
Okay, we're at slide 35. Okay, the clinical education is targeted program educate or TPE, medical review hot topics for TPE, and new hospital outpatient or OPD prior authorization CPT codes. Slide 36. The targeted program educate process resumed effectively on September 1st of 2022. And Palmetto Gba may select providers for the TPE process based on, but not limited to, the following reasons: analysis of billing data, indicating variances, or on targeted review and its transition to the TPE process based on error rate or results, or on the service-specific error rate results. And there's a link provided if you would like to look at that information as well. Slide 37. This is the targeted probe and educate process. The TPE process remains the same. It still consists up to 3 rounds of review with 20 to 40 claims that are samples selected for sampling, whether it's pre-payment or post-payment for each round. In addition to the provider notification letter, additional documentation requests will be generated for each claim selected. For prepay reviews, Palmetto Gba will conduct the review within 30 days from the date of the documentation is received and make a payment decision. For post-pay reviews, Palmetto Gba will conduct the review within 30 days from the date the documentation is received and make a payment decision. And please provide the documentation that's requested in the ADR within 45 days of the ADR date that's on the letter, because you don't want to wait till the last minute to send in your documentation until like the 44th day or like the 45th day, because we don't get it the day that you send it in, and it has to go through the process of everything. So just make sure that you send it in so you won't receive any type of error for not sending your documentation in timely. Next slide, please. These are the medical review hot topics for TPE. They are looking at therapeutic exercises, hyperbaric oxygen therapy, or HBO. They're also reviewing neuromuscular re-education as well as manual therapy, end-stage renal disease, psychosis, also end-stage renal disease, renal dialysis, SNF, or there's a skilled nursing facility, inpatient rehab services for neurological and stroke, and drugs and biologicals, which drugs and biologicals is always one that medical review looks at. The next slide, please.
Sandra, before we jump to the next slide, I had a question come in that I wanted to share with you. Is it possible to have the TPE letters sent to a different address than the normal correspondence address? For example, can the letters be sent to a corporate address instead of a lockbox address?
Well, there is, so correct me if I'm wrong, there's a form that has to be completed for that. And depending on where certain correspondences go, that's where that, everything will go in that category. I can shoot you find the link with that information on it, and they can look at that information to see if TPE letters can go to a different one. But usually it will come into the e-services. Isn't that correct, Charles? Have they started doing that, putting them in e-services, right?
Yes, and also the provider can change their medical review correspondence address, because that is the first address they use in the provider enrollment file. So they can complete the 855 change form and change that medical review correspondence address to wherever they want it to go.
And Bill, I can send you a link and you can get that out.
Yeah.
for them, okay?
Thank you.
So now we're on slide 39, and this is the cervical disc removal and spinal cord simulators, or OPD. The next slide, please. The Centers for Medicare and Medicaid Services, or CMS, will now require hospital outpatient department prior authorization for the following CPT codes for cervical fusion with disc removal and spinal cord simulators, or SCS, as a condition of Medicare payment. The provider must submit to the Centers for CMS or its contractors a prior authorization request for any service on the list of the outpatient department services requiring a prior authorization. The prior authorization should be submitted, and the provider should have received an affirmed decision before any services are rendered. So these are the new codes that now require prior hospital outpatient prior authorization.
Okay.
Okay, next slide, please. Palmetto Gba considers FDA-approved prosthetic cervical disc reasonable and necessary of treatment for beneficiaries with symptomatic cervical disc degenerative disease or herniated disc at a single level, and they have to meet the following criteria. The device is approved by the FDA. The beneficiary has to be skeletally mature, and the beneficiary has to be intractable, have an intractable cervical radicular pain or myelopathy, which has failed at least 6 weeks of conservative non-operative treatment, including physician-directed pain management, or the beneficiary has severe or rapidly progressive symptoms of nerve root or spinal cord compression that requires hospitalization or immediate surgical intervention. Next slide, please. For general documentation requirements, be sure to include your documentation that the condition that requires the procedure, the physical exam, including the beneficiary's pain, the duration, the character, location, and if the pain radiates. Also, any clinical evidence that shows nerve root or spinal cord compression and or cervical degenerative disc disease. Include limitation with activities of daily living, imaging reports, that are MRI, your CT scans, or your mammography when submitting your documentation. Also include all progress, pre-op, and post-op notes and any treatments that were tried and failed. Next slide, please. You can include the conservative treatment modalities, but they're not limited to physical therapy, injections, medications, any type of assistive devices that were used, and activity modifications. Next slide, please. Now we'll go over the spinal cord simulations of SCS. Next slide, Bill. The informed consent. A signed informed consent is required because this is an invasive procedure that carries surgical risk, just like any other surgery. The patient should be informed that there is a potential risk for bleeding, infection, spinal cord injury and or paralysis, and nerve damage that is associated with weakness and numbness. Next slide, please. Prior to a patient having SCS placed, the patient must be screened and meet certain criteria. Pain is not associated with malignancy. Poor response to conservative treatment for a minimum of 6 months. And revision surgery is not an option or would have a low chance of success. The patient cannot have a pacemaker or any other medical contraindications. And there are no major psychiatric disorders, including this word I always get tongue-tied, somatization, willingness to stop the inappropriate drug use prior to implementation, and no related litigations, and the ability to give signed consent for the procedure. Next slide, please. Documentation of psychosocial evaluation must be documented. Also, for permanent placement, include the documentation of the pain relief with a temporary implanted electrode with at least 50% reduction of targeted pain or 50% reduction of analgesic medications. Next slide, please. These are checklists. They're not mandatory that you use them, but we highly suggest that you use them to make sure that you can receive an affirmed prior authorization before the procedures are actually performed. And you could just use this checklist. It's helpful for your staff and to make sure that you have everything that you need prior to submitting your prior authorization. The next slide, please. These are the LCDs that you can refer to. If you don't want to use our checklist, you can create your own, and you may use these LCDs using the links that are provided here. The next slide. These are some the resources for the Palmetto Gba website. Select your email updates. You can receive email updates and for e-services as well as the CMS website. And before we end today, I would just like to invite everyone to attend our May Fest, which is May 10th, starting at 10 a.m.
Yes, 10 a.m.
Yes, starts at 10 a.m. and you can go in and you can select the different, whichever session you would like to attend. You can go on and register for that. And also we'll be doing a IMRT webinar on next Thursday afternoon at 1 p.m.
Okay.
And the next slide, Bill. And as always, you can connect with us on Facebook, LinkedIn, Twitter, as well as YouTube.
Okay. Great. Great. Does that conclude your presentation at this point?
It does.
Wonderful. I appreciate it so much. Anybody out there have any questions for the folks at Palmetto Gba? When you think of just the day-to-day processes that you go through, following up on claims, checking a claim status, getting assistance with a claim, any issues that are coming up with claims that are denied that you want to ask general questions of them, anything that was not discussed today. And I apologize, someone had asked if there was going to be any discussion specific to physician issues and whatnot, and I apologize that we didn't drill down into that deeper for you. Sandra, what would your suggestion be if somebody wants some additional information as it relates to the physician billing side of Medicare claims?
The physician billing side?
Yeah, if they had some more specific questions related to the physician side, is there, there's sometimes some unique differences and whatnot. Anything you would suggest to them as far as getting their questions answered? Still go through you guys?
They could actually, A.dot policy, I believe that's it. If they have more specific questions that they may want to ask someone from, related to policies or whatever. Is that correct, Charles? Am I leading them in the right direction?
Yeah, if it's more policy dot questions, A.dot policy. There is a billing webcast April 27th about physician billing, and it has a lot of good scenarios that they're going to go through. So they can go to the Palmetto Gba website and sign up for that. It is April 27th. I think it's at either 10 or 11 o'clock.
Okay. Thank you, Charles. Another question that came through, are there any changes with the Georgia modifier or with the ABN for outpatient hospital?
There have been some discussion. I'm sorry. There have been some discussion, but nothing has been finalized as far as changes. But there have been some discussions, but as of right now, nothing is official.
And any changes will be pushed out through the website and I guess any member newsletter or whatever.
That's correct.
Okay. What other questions? Let's see. Oh, here we go. How do I find the reason codes when a claim is being, how do I find the reason code? How do I find what the reason codes are when a claim is being denied? I have no luck finding specific codes showing on the claim on Palmetto Gba.
Usually, you can go to medical review if you do your search in the search box, do medical review denials, and usually if you search medical review, they usually have, I'm looking right now so I can tell you exactly how to get there. Because they usually have a list of codes on what the codes mean.
Okay.
You go to medical review and then denials. There's a list of denials there, and you can scroll all the way at the bottom and it'll have an entire list of reason codes, and it'll give you ways to help prevent those particular denials.
Okay.
If you go do your search engine with medical review and then
denials.
Denials, yes.
Okay. Okay. Another question, does Medicare pay for E&M services if there is no auth on file, but the medical records support the services?
Okay, but auth on file, are they talking about the physician signature? Is that what they're talking about? Authentication of the provider?
Well, any pre-authorization for those E&M services, I guess.
Oh, okay. I'm sorry.
Yeah.
For Medicare, you do not need prior authorization for E&M for traditional Medicare. Now, for Medicare Advantage, you're looking at something different. But for fee-for-service Medicare, E&M does not need any type of prior authorization.
Okay. Just want to make sure everybody's good with that. Any follow-up from that? Here's another question. Why is Medicare requesting providers to resubmit claims denied due to Medicare Error 237 versus Medicare initiating a reprocessing? Also, can you confirm how we can obtain a copy of this presentation? And I'll explain that here in a little bit. But why is Medicare requesting providers to resubmit claims denied due to Medicare Error 237 versus Medicare just initiating a reprocessing of the claim?
Well, I can answer that. With the 237, sometimes those are Medicare system errors and sometimes they are legitimate errors. So we cannot just adjust every claim in that situation because some of them are legitimately incorrect. So That may not be the most popular answer, but that's the reason they just don't mass adjust all of them at the same time, and the providers have to resubmit.
Let me see here. Any follow-up from any of those other questions? I'm not seeing anything. See if let me just double check, see if I missed anything. Okay. Okay, I think that just about gets all of our questions. Let me see, we'll give folks another second here to submit anything. Hey, I'm going to put my ugly mug on the camera here for a second. Hope everybody enjoyed the presentation today. I was reminded or informed, I guess you could say, that we are Georgia HFMA is no longer posting presentations on the website. So what we're going to do is, if you were registered for these payer forums this week, we're just going to make sure that you get a copy of the presentation. Several people have asked for it, and we will do our best to get that to you. If for some reason you don't get that in the next several days, please follow up with me. My email was on the initial registration, so I'll be happy to get that to you. And as is always the case, check your junk mail, because nowadays it seems like a lot of stuff is dropping into those junk mail folders. So, oh, I got a question popping up. Let me catch this real quick. Nope, that was just a quick follow-up. Nothing there. So, Charles, Erika, Sandra, I appreciate your continued support of Georgia HFMA, and just really thank you for your time today. No worries on the connectivity. It seems to just be an inherent issue that we're going to need to work through, and we'll try to figure it out going forward. But thank you so much for your participation. And I'm going to just take a quick second here. People are asking for my email address so that they can send me all kinds of good stuff, questions and whatever. So let me do that. I just added that to the chat, and I'll make sure that we get that. But I want to thank all of you for your participation and for your support of Georgia HFMA. I encourage you to check the chapter social media sites for any upcoming events. There's a lot of good education provided by the chapter. Also, any feedback on anything that you think we're missing or need to hit on with these presentations. We're trying to keep the lines of communication open between providers and payers. I know that it's an important relationship in the success of your organization. So I encourage you to use the resources that they make available to you. And if you have questions, don't hesitate to collaborate with one another, get to know some of your counterparts at other facilities so that you guys can put your heads together and sometimes figure out maybe the best answer or best way to resolve some of the issues that you're running into on a daily basis. But Georgia HFMA is here to support you in the work that you do, and we thank you so much. And let me just check one more time, make sure I'm not missing anything. All right, I think I've got that. Let's see. Yep, that should just about cover everything. So with that being said, I think we're going to close out the session for today. Tomorrow, we've got United Healthcare is presenting at 1 o'clock. And I'm going to get on about an hour and a half early with them to make sure we can get them connected appropriately. And hopefully we won't have any unexpected delays. Thank you for your patience today. And we will look forward to having you with us the rest of the week. Tomorrow's United Healthcare. Thursday is Anthem Blue Cross. And on Friday, we've got Centene, which is going to be primarily focused on Ambetter, followed by Humana. So again, thank you, everyone. We appreciate your participation. Hope you have a great rest of your day.
Thanks, Bill. It's always a pleasure.
Thanks so much.
Thank you.